Eawag seminar. It is my distinct pleasure to welcome Christian Althaus, who is the head of the Interfaculty Program for Data and Computational Science at the Institute of Social and Preventative Medicine at the University of Bern. He's also one of the leading voices in managing and handling these COVID-19 pandemic in Switzerland. Before his work at the Institute of Social and Preventative Medicine, he completed his PhD at Utrecht University in theoretical biology and bioinformatics in the Netherlands, and worked as a research institute for the Institute for Ecology and Evolution at ETH Zurich. And so with that, I warmly welcome Christian and all of you. Thanks for coming. And of course, Christian will be taking questions at the end if there's time. So please feel free to participate in that. So thank you very much, Christian.
Thank you, Tim. Hello, everyone. Thanks very much for giving me this opportunity to talk about the pandemic in Switzerland and also our work at this seminar in Eawag. We just had a very interesting exchange about research, and I'm very glad we can have this talk and discussion in this interdisciplinary setting. So what I would like to talk about today is why time is of the essence when it comes to outbreak response, and I want to illustrate that with the example of the successful containment of the SARS-CoV-2 epidemic during spring in Switzerland from February to May 2020, and then basically highlight the lessons that should and could have been learned to deal with the current situation and future situations with this epidemic. So before I start, I want to highlight this quote from Dr. Tedros, which is the Director General of the World Health Organization, who said on February 11, so 8 months ago or more than 8 months ago, when basically we saw what happened in Wuhan, in China, with this pandemic, when it was very clear that the risk for global spread is high, and that every country globally needs to prepare for this situation. He said that's a window of opportunity, meaning basically the coming weeks before the virus arrives. So I'm reminding there is time, the time is ticking, and time is of the essence in this outbreak. Who was involved in this work? I'd just like to mention my colleagues that have been involved in this work in one or the other way. So in particular, Julien Rioux and Anthony Hauser, but also Michel Kunert and Nicolas Lowe from our institute here at the University of Bern, the Institute of Social and Preventive Medicine. Also Daniel Probst, who you might know, who is the man behind Corona data that provides us with a nice visual interface to see the trend of the epidemic. He used to be a PhD student at the University of Bern. Then also Garifalos Konstantinoudis, who used to be a PhD student at our institute, but is now at a postdoc at Imperial College in London, and Charles Margosian, who is at Columbia University in New York. So we have a pandemic, and we had to prepare since January for that situation, and basically to set the stage at the very beginning when there is an emerging infectious disease appearing anywhere globally, as it has happened a few times in the past decades. There are mainly two key questions for the early outbreak response. One is, what are the transmission characteristics of this new pathogen, virus or bacterial, in terms of the reproduction number R0, and also in terms of potential for super spreading? And second, of course, we are interested in the severity of the disease, or what we call infection fatality ratio, in order to really anticipate the threat to public health that basically this new pathogen could represent. We have been fortunate at our institute to be able to contribute actually to both of these questions quite early on, and I'd just like to give you a little overview for that to really set the stage into what's we did afterwards. So very early on, when there was basically the epidemic in Wuhan in China, we tried to understand the transmission characteristics of this new virus that was at that time called Wuhan 2019 coronavirus, I think. There was very little data, but what we did know was estimates about the true epidemic size around mid-January, or shown here on January 18, between 1,000 and 10,000 infected individuals. That size was estimated based on the occurrence of new infections in travelers outside China, and also based on the sequence analysis, or the quite early sequences that were available throughout January. So that was a very rapid scientific effort to have these sequences available. We had information about the potential start date of this outbreak, or the time of the most recent common ancestor, that gave us basically this start point of the outbreak. And we then let basically different viruses simulate with different viral characteristics, so we could sort of pinpoint which sort of virus could have led to this outbreak in Wuhan. And that resulted in this graph shown here. So we characterize basically these different viruses by the basic reproduction number shown here, which is the average number of secondary infections generated by one infected individual. I'm sure you all know that number now very well, because it has been in the media throughout the year. If this number is above 1, the virus can really spread efficiently between humans and constitutes a threat for global spread and a pandemic. But we also have another parameter that we call dispersion parameter K, coming from a negative binomial distribution. This parameter describes the potential for superspreading of a pathogen. So if this parameter is low, significantly below 1, that means that we have to deal with a pathogen that can exhibit these superspreading events, like they have been observed for the related virus SARS-CoV or SARS-CoV-1 from almost 20 years ago in Singapore and Beijing. So they were characterized as the new SARS-CoV-2 viruses with reproduction numbers between 2 and 3, but with quite a significant level of superspreading. And as a comparison, we showed here values for the pandemic influenza from 1918 that had somewhat lower values for the reproduction number and higher values for this dispersion parameter K, meaning that influenza is typically thought to exhibit less superspreading events. And we can clearly see here from this graph, the sweet spot where this new coronavirus now probably lies, that it can transmit very efficiently, also with reproduction numbers between 2 and 3, and that it also shows occasional superspreading events like SARS, but not as much as SARS, which makes it much more difficult to contain. Also, we did some work on the second question, which is about the severity of the disease, or the infection fatality ratio. We did an analysis for 6 European regions. So this was work mainly done by Julien Rioux and Anthony Hauser. And we see here actually for Austria, Baden-Württemberg, Bavaria, Lombardy in Italy, Spain, and Switzerland, that we estimate with statistical methods this infection fatality ratio quite consistently, around 0.5% and 1%, depending a bit on the country and the epidemic situation they had with overwhelmed hospitals. But that gave a very consistent picture about the infection fatality ratio, which is the proportion of infected individuals that die as a result of the infection. We see here in this bottom panel the very strong age-specific infection fatality ratio, which is relatively low for people below 40 and 50 years of age, and then really kicks in with 60, 70-year-olds and basically increases exponentially for the elderly. And also, so these studies were then later on very well confirmed by seroprevalence studies, mainly one important study done in Geneva, published in Lancet Infectious Disease, but also with seroprevalence studies from Zurich, other cantons in Switzerland, and countries like Spain. So again, that sets the stage. We have to deal with this new viral threat with a relatively high basic reproduction number, so it can spread efficiently. It exhibits occasional superspreading events, which makes it challenging to deal with. And we have an infection fatality ratio that cannot be ignored, around values of 0.5% to 1%, which really makes it a public health threat. Of course, there were always these discussions about comparisons to other pandemics and other infectious diseases such as seasonal influenza. And I think this graph here nicely illustrates the strong age-specific infection fatality ratio in red that we see for SARS-CoV-2. So this is a logarithmic scale, and we see these straight lines, so showing that the infection fatality ratio almost increases exponentially, and the difference to estimates for seasonal influenza shown here in blue for different seasons. So that's coming from data from the US Center for Disease Control, CDC, and we nicely see this roughly tenfold difference in the infection fatality ratio for most age groups, except for the very young, where the infection fatality seems to be very low and roughly the same between SARS-CoV-2 and the seasonal influenza. On top of that, of course, it's very important to mention that different to seasonal influenza, because there is no or almost no pre-existing immunity to SARS-CoV-2 in the population, the proportion of people that actually can catch this virus and get infected can be very high and more than 50%, whereas typically for seasonal influenza, only about 5 to 20% of people get infected every year. So with that background, I like to start to talk about the main project, which is about the containment of the SARS-CoV-2 epidemic in Switzerland from February to May 2020, and the lessons that we can learn from that phase of the epidemic. So these are two graphs coming from a very nice publication from colleagues of mine around Joseph Lemaitre and Jacques Fellet from the EPFL in Lausanne. On the left-hand side, we see the time points at which different so-called non-pharmaceutical interventions, NPIs, were introduced during the spring epidemic. Maybe you remember these events at the very beginning on March 28. There was the first intervention, which was a ban on gatherings of more than 1,000 people, shown here as the first intervention. Then we had some recommendations for social distancing and home office. Another important intervention to school closure around March 13, 14. Then in 3, the closure of non-essential activities, shops and venues. That was basically sort of what we called the lockdown in Switzerland on March 16 or 17 when it went active. And then possibly also quite important with 4, the ban on gatherings of more than 5 people that was then actually introduced a little bit later on March 20, which arguably was also a very important NPI that was implemented. We see here the gray bars. These are the number of confirmed cases per day during that time. So that was around the time of the lockdown still quite low, and then increased a little bit for about a week or 2 afterwards, and then led fortunately to a very successful containment and rapid decline in the epidemic. On the right-hand side, we see the variables that we're possibly more interested in, which are basically the healthcare burden or the load in the hospitals. So here in magenta, we see the number of hospitalized patients that exceeded 2,000 during the peak of the epidemic, somewhat shifted compared to the confirmed cases, and in particular after the introduction of the strong measures, because basically of this delay period at which people develop symptoms, are then admitted to hospitals and then have to stay in hospitals for 1, 2, or 3 weeks. We also see the load in the intensive care units shown here. That was between 400 and 500 patients maximally around the beginning of April, and then the increase in the number of deaths that shows actually the longest delay that sort of came to around 2,000 deaths during the spring epidemic. So what they also did in this study by Joseph Lemaitre and others, they used quite a sophisticated stochastic model with Markov chain Monte Carlo techniques to estimate the time-varying reproduction number or the effective reproduction number during this spring epidemic. And that's shown here, where we nicely see that these values of the reproduction number between 2 and 3, or sort of 2.6, 2.7, at the beginning of the epidemic, where there was uncontrolled exponential spread. At least from this study, we can also see that actually this early ban on large events of more than 1,000 people actually did not contribute to a change in the reproduction number. Possibly this intervention was very important to prevent further spread across all of Switzerland, but actually the infection was seeded already in pretty much each canton, so that possibly didn't have a big impact on the overall reproduction number. However, then during 1 and 2, when more accommodations were implemented, social distancing, hygiene measures, and home office, we see this reduction in the reproduction number. Around the time of lockdown, here in 3, we see that the reproduction number was still above 1, which would still have led to further exponential spread of the epidemic, but then it slowly started to decline. And then with the final measure, the limit on gatherings of 4 people, it really significantly dropped below the critical threshold of 1, which then led to this rapid decline in cases and the successful containment of the epidemic. So overall, we can say it took about 2 weeks to go from this baseline level of the reproduction number to the containment phase during the spring lockdown. So we also tried in a similar way to our colleagues to describe this epidemic in spring using a so-called compartmental transmission model, so where the population is compartmentalized into different characteristics, and that then can be translated into a set of ordinary differential equations that are shown here. So just briefly to explain that, we typically characterize this population according to a so-called SIR model, where we stratify the population to susceptible, infected, and recovered individuals. Here we have the susceptibles that get exposed during an incubation phase, then become infected or infectious individuals. These individuals then can progress further with their disease and either just recover and be fine again, or they are admitted to a hospital. In the hospital, they can continue to be in hospital beds, or after a few days have to be admitted to an intensive care unit called U here. Then both within the hospital, normal hospital bed, and the intensive care units, these patients can die or recover within the hospital, stay in the hospital for another while, and then basically go back home. So we use maximum likelihood estimation techniques to use this model and fit it to the data, and that's shown here in this graph with 4 panels. So we fit the time series of this model to data of hospitalized patients here that reaches this maximum with about 2,000 patients. The people in intensive care units shown here, around 400 patients in intensive care units at the peak, and the number of daily deaths that reached a peak of around 50 to 60 deaths per day during the spring epidemic. So importantly, with this model, we do not rely on the confirmed case counts, because we don't know exactly the level of underreporting or under-ascertainment in these cases, but basically we can calculate back the expected number of new infections per day, shown here with this line on a logarithmic scale. So we see the increase and the decline of the epidemic, and then basically the difference between the true number of new infections and the actual confirmed cases by day then gives us an idea about the underreporting of infections. But importantly here, first of all, we can actually describe this epidemic quite well with such a model, and that's typically the case because epidemics increase exponentially once we introduce control measures. They decline exponentially, or once the population of susceptibles is depleted, which fortunately was not yet the case in Switzerland. What we can learn here from this rapid increase and decline in the number of infections is we can look at the doubling time, and we see that the epidemic doubled every 3 days during the spring epidemic in the first days of the month of March. And then during the lockdown, the number of new infections reduced by 50%. So they had a half-life of around 9 days, meaning that 1 week of early exponential spread required roughly 3 weeks of lockdown to reduce the number of infections to the same level again. So we cannot more efficiently suppress the virus than it was done with these lockdowns, meaning that we require always more time of lockdown than we spend for early exponential spread, highlighting that it's actually very important to act early because that reduces the time of that necessary measures need to be implemented. In this graph, we more closely look at the underreporting of SARS-CoV-2 infections during the spring epidemic. So that's basically the ratio of the estimated number of true infections and the number of confirmed cases. So we see that we had captured around 10 to 20% of infections before the lockdown. And then with the lockdown, we sort of lost track. There was also less testing done again. And then we missed about 9 of 10 infected cases during the lockdown. So that's the result basically from this statistical model, but that also confirms results from zero prevalence studies that then were done later on, and in particular of the important study that was done in Geneva, where they concluded that they estimated that for every reported confirmed case, there were about 11 infections in the community. The level of underreporting might differ a bit across cantons, and for example, could have been a bit lower in the canton of Zurich compared to the canton of Geneva. So what we wanted to do with this model, once basically we could describe the spring epidemic quite well, was to investigate counterfactual scenarios of earlier and later implementations of the non-pharmaceutical interventions. And as you all remember, there was the time when different countries in Europe reacted differently, also depending basically on the state of the epidemic in these countries. And that's illustrated in this panel coming from a nice study by our colleagues at the Imperial College around Peter Flaxman, I think, published in Nature, where they analyzed the epidemic in different countries. And we see here that the major NPIs that were implemented, such as public events that were banned, and basically the delays that different countries had, here in particular the UK and Sweden, also school closures that were ordered, which not always includes primary school, but could just include upper education as well. And then sort of the strict lockdowns that were ordered that of course differed in different countries. And maybe to highlight here, Sweden was not part of that. They did not have a strict lockdown, but basically implemented all other measures as well. On the right-hand side here, we see basically a schematic representation of this change in the effective reproduction number that was also found in the study by Joseph Lemaitre that happened in Switzerland. So we had this 2-week period at which the reproduction number dropped from values around 2.6 to values below 1, which led to the successful containment. And we were now interested to investigate what would have happened with the epidemic if basically the sequence of NPIs that were introduced in Switzerland shifted. So if all the whole sequence of these NPIs would have been introduced a few days earlier or a few days later, how that would have affected the load on the hospitals and also the burden in terms of expected death for such epidemics. So we basically shifted just this change in the reproduction number for a different number of days. And that's shown here in this table. maybe the numbers are a bit small, but I can talk you through these numbers. So in the middle, we have 0 days. That's the actual situation that happened in spring, where we had, for example, maximally around 40,000 new infections per day. We had about 250,000 infections in total. We had this maximal load in hospitals of more than 2,000 patients, more than 400 patients in ICU, around 60 patients at the peak that died per day, and around 2,000 patients in total that died. So when we look what would have happened if all these NPIs were introduced 1 week earlier, which doesn't sound like a lot, but remember that the epidemic was doubling every 3 days during the late days in February and the early days in March, we actually see that we only would have had 50,000 infections in total. The maximum number of hospitalized patients would be around 400, less than 100 patients in ICU at max, less than 16 patients dying per day, which gives a total of around 400 deaths compared to the 2,000 that we had in Switzerland. Maybe more impressive and dramatically, what would have happened if we acted later and Switzerland would have introduced this sequence of NPIs, all of them 1 week later. Remember, again, the doubling time of 3 days during the early phase of the epidemic. So this would have led to more than 1 million infected cases. The maximum number of hospitalized patients would be more than 10,000, so possibly exceeding hospital capacity. Maximum number in ICU would be close to 2,000, also possibly exceeding, or at least the capacities that were available at that time. And we would have had almost 9,000 expected deaths in Switzerland, clearly illustrating that it was very important to introduce this sequence of NPIs quite early in Switzerland. So the summary and the message from this data is, of course, that the rapid implementation of non-pharmaceutical interventions, or NPIs as we call them, in the case of a resurgence of the epidemic, can first limit the necessary duration of strict control measures, as we've seen. So we needed 3 weeks of lockdown for every week of uncontrolled exponential spread before the implementations of NPIs. And also importantly, or subsequently, this would lower the cost, not only for health, as clearly shown in this table, but also for the economy because of the shorter duration of these interventions and overall for society. So rapid acting early and implementing NPIs early on seems to be key in responding to these outbreaks. So how have we ended up in a situation like this again? This graph coming just from the newspaper from today, I think is quite disturbing a bit for us in Switzerland. So basically we overtook all our neighboring countries, in particular Germany, that seems to have quite a good approach or is dealing comparably better than many other European countries to respond to this pandemic. So these numbers just reflect the daily confirmed cases, which of course don't reflect the overall picture about the epidemic and not necessarily the load on the hospitals, but that starts to look actually quite similar for Switzerland. So what happened? As you all know, Switzerland had a very successful lockdown, but lifted measures very rapidly during June and July with hardly any measures left in place with respect especially to gatherings in the events. So there were very high upper limits for gatherings and events compared to neighboring countries. That resulted in a slow but consistent exponential increase of the epidemic in confirmed cases, while hospitalizations and death rates stayed at low levels. They increased at the same pace throughout the summer. And that meant that we already started autumn with quite some infections around, with more than or several hundreds of confirmed cases reported every day. We also know that contact tracing in Switzerland started to become less efficient. So contact tracing teams could not keep up with the high confirmed case counts in Switzerland. And then with the autumn weather, as expected, that made the situation more challenging because of the colder and wetter weather when people stay more inside. So it was sort of expected that actually that could lead to a much faster growth and sort of an explosion, in particular because contact tracing teams could not keep up with the numbers, and also because the epidemic spread to almost every corner in Switzerland and to populations and areas where apparently very little control interventions were put in place. So could the situation have been prevented? Maybe that's the question. I think yes. If we look actually at recommendations that were done by the Swiss National COVID-19 Science Task Force early on. So this task force came into existence at the end of March or early April. And this is actually the executive summary of one of the very first policy briefs, which gives a proposal for a transition strategy with lifting and implementing measures in order to keep the epidemic in check. So there it was highlighted that the relaxing of control measures can be justified only if the effective reproduction number is substantially below 1, and if the indicator variables such as daily confirmed case numbers, daily hospitalization rates are below a critical release level. So as we all know, during June and July, that was not considered an important recommendation or a guidance. So all these measures were lifted despite the clear warning that the reproduction number is above 1 and that the epidemic trend clearly goes into the wrong direction. Maybe more importantly in this document, it was also said that measure must be tightened immediately if the reproduction number becomes larger than 1 with sufficient statistical certainty, and or if the indicator variables are at or above a critical level. So that means actually with the situation that we experienced in early October, when we started to see this very rapid increase of confirmed cases, that it would have been very important to tighten measures, to introduce new control measures as they were done yesterday, in order not to let the epidemic again double for several times during the past weeks, in order to really risk basically an overload of the hospital system. So how do the current epidemic trends in Switzerland look like? That's just an illustration of the 4 key variables that we look at. So on the top left, we have the daily confirmed cases. On the top right, we have the daily hospitalizations, clearly exceeding more than 100 per day now. We have the patients on intensive care units, which is now above 200, and the daily death, which are around 15 to 20 at the moment. So all these variables, as you see, beautifully, they have a very consistent exponential increase with a doubling time between sort of 6 and 9 days. So far, they all seem to increase. And now with the introductions of new measures in different cantons during the last days, and now also on the national level from yesterday midnight onwards, of course, it is to be hoped that this trend can be reversed, but it's important to remember that all these variables will increase at least for a few weeks, because there is always this delay period, and it will take a while until we see the effect of these measures in the different variables, and especially in the hospitals. That's particularly concerning for the capacity of hospital beds or in beds in intensive care units in Switzerland. That's a graph that is now regularly updated by the team around Tom van Böckel from the ETH in Zurich, and that is used by the Swiss National COVID-19 Science Task Force to basically follow the trend in ICU occupancy and illustrate the risk of overload of the hospital system. So in this graph, we see the occupancy in ICUs. Here in green, we have the current limit of around 1,000 beds. In red, we have the maximal ICU capacity. So we could add a few hundred beds to around 1,400. We see the non-COVID patients in the intensive care units, also shown here in the two different grays. And in green, we have the COVID-19 patients. So we see here from the spring epidemic that we actually exceeded this standard limit of around 1,000 beds just slightly. Then we had this stable situation during the summer, and now we face again this rapid exponential increase. So this graph is actually 1 week old, shown here when we had around 100 patients in intensive care units due to COVID-19. So we can nicely extrapolate what we've done 1 week ago already with a doubling time of 7 days, which is now the consistent doubling time for all these variables. So we end up at about 100 more patients in the ICU, 200 in total. And if we continue with these trends like that, here, given some variation with doubling times of also 5 days and 10 days, depending whether the epidemic actually accelerates or slowly goes down, we really face basically the threat of an overload of ICU capacity in the coming weeks. So here shown between November 5 and 18. And it will be very important to bring case numbers down that this won't happen. So what are the challenges ahead, given this current situation in Switzerland? So we have, as I've mentioned, these newly introduced non-pharmaceutical interventions on a national level yesterday. They do not represent a lockdown, so a lot of activities are still allowed, and therefore, compared to the situation in spring, it remains questionable whether that's sufficient to push the effective reproduction number below 1, which will be necessary in order to avoid a healthcare system overload. I think we can say that basically we will need the same effect that we had during the spring lockdown, where the effective reproduction number dropped to values around 0.7, which can lead to a rapid reduction in infected cases and basically reduce the load on the hospital system. And this time, this will only be possible with an additional behavior change. So we will need this behavior change, and people actually should possibly act as if there was a lockdown in Switzerland. Otherwise, it will arguably be very hard to push the reproduction number below the critical value of 1 during the coming days and weeks. So at the moment, an overload of ICUs and hospital beds in any case cannot be ruled out during the next 2 weeks. So these measures were implemented very late. We are far beyond the point that we had during the spring lockdown. So this time we definitely risk an overload of ICUs and hospital beds. And I think this can be summarized with the fact that the situation this time is much more serious than in spring. So we acted, in fact, not earlier, but later in spring. We are beyond the point of the lockdown, which was introduced on March 16, 2020 by roughly a factor of 2. So if we look at the hospital variables and ICU occupancy, we are about by a factor 2 beyond the time point of the lockdown in spring. And there is also the winter still in front of us. So the situation is much more serious and much more challenging than in spring. And to conclude, I can only reiterate that time is of the essence in this outbreak, as it has been said by Dr. Tedros a long time ago. As it has been known, and as we've seen with the spring lockdowns or the introduction of non-pharmaceutical interventions, and this will remain for the current situation and throughout all of winter and next year. And I think it's very important to act accordingly and to remember that acting swiftly and decisively is always the better approach than waiting and wasting time and letting this epidemic escalate in a population. And with that, I'd like to finish and remind you that we can also possibly learn a few lessons from this pandemic, because it's arguably not the biggest threat that we as a society or humankind face in the future and during the coming decades, because there are more sort of natural catastrophes in front of us, and hopefully we can learn a few things from this pandemic in terms of responding early and decisively to basically tackle challenges that might lie ahead in the future. And with that, I'd like to finish and thank you for your attention.